Hello and welcome. Let's talk about antidepressant drugs. So, what are the aim and objectives of treatment of depression? To relieve symptoms of depression, to restore normal social behavior, and to prevent further episodes. Now, antidepressive drugs. Tricyclic antidepressants, which includes amine reuptake inhibitor of first generation like imipramine, amitriptyline, nortriptyline, desipramine, chlorpheniramine, trimipramine, doxepin, and protriptyline, and selective serotonin reuptake inhibitors like fluoxetine, paroxetine, and sertraline, MAO inhibitors like phenylalkyne and tranylcypromine, atypical drugs which include second generation drugs like amoxicillin, metprotilene, bupropion, and third generation drugs like nifazodone, venlafaxine, and mirtazapine. Now, pharmacokinetics of TCS: highly lipid soluble, rapidly absorbed mainly from small intestine, high fast pass metabolism, high plasma protein binding, large BD, and metabolism by liver. The active metabolites includes desipramine, imipramine, nortriptyline, and amitriptyline. Now, SSRIs: well absorbed, high plasma protein binding, long half-life 15 to 24 hours, metabolized in liver. Active metabolites includes norfloxacin, very long half-life and once daily dosing. MAO inhibitors: readily absorbed from GIT, non-selective, metabolized by liver and excreted by kidney. Now, second and third generation: similar to tricyclic antidepressants, shorter half-life, some of active metabolites, and drug effects will persist for 7 days to 2 to 3 weeks. Now, mechanism of action: tricyclics. Tricyclics block the reuptake of NE and or 5-HT into noradrenergic and or serotonergic terminals by specific interaction with the plasma membrane transporters and result in the increased levels. TC also blocks cholinergic, alpha-1 adrenergic, and H1 histaminic receptors. Selective serotonin reuptake inhibitors blocks the serotonin reuptake in serotonergic nerve and increases the serotonin level in synaptic cleft. Now, MAO inhibitors. These drugs irreversibly inhibit monoamine oxidase enzymes, which is mainly responsible for the degradation of the monoamines, which permits more amines to accumulate in the presynaptic store and more to be released. It has non-specific action, and specific action is by moclobemide. Second and third generation have no any common mechanism of action. These are more similar effects like TCA and amine transport, and some very less effects on reuptake and metabolism. Now, this is a picture showing the action of the MAO inhibitors and TCAs and SSRIs. Now, pharmacological effects: TCH, less selective, mostly long-acting, sedation, postural hypotension, dry mouth, constipation, broad vision, risk of ventricular dysarrhythmias, confusion, and mania. SSRIs include selective efficacy similar to TCH, currently most commonly prescribed drug, toxicity lesser than TCH, less risk of overdose, no food reaction, and dangerous serotonin syndrome with MAO. MAO inhibitors includes long-acting atropine-like effects, weight gain, and side effects like postural hypotension, CNS stimulation leading to restlessness, insomnia, and liver damage. Should not be given with TCA or SSRIs. Hypertensive crisis with tyramine containing food cheese reaction. And second and third generation includes different mechanisms of action, non-selective, and acts mainly as non-selective antagonist of presynaptic receptors, possibly enhancing amine release. Therapeutic response similar to TCAs and MAO inhibitors, and toxicity less than TCAs. Clinical uses includes for depression, for anxiety disorders, obsessive compulsive disorders, in case of enuresis, chronic pain, and eating disorders like bulimia, attention deficit disorders, premenstrual dysphoric disorders. Now, adverse effects: TCS includes cardiotoxicity, coma, confusion, and autonomic side effects, and weight gain, sedation, anticholinergic effects, CVS, orthostatic hypotension, conduction defects, arrhythmia, tremor, insomnia, psychiatric aggravation of the psychosis, and others. SSRIs includes anxiety, agitation, sexual dysfunction, seizures, weight loss, GI symptoms, decreased libido, and others. Serotonin syndrome like hyperthermia, muscle rigidity, myoclonus, and rapid changes in the mental states and vital sign. MAO inhibitors includes weight gain, dry mouth, postural hypotension, headache, drowsiness, sexual disturbance. And second and third generation drugs includes same effects like TCH, SSRI and MAO inhibitors. Now drug interaction. Antidepressant drugs with alcohol causes additive effects. MAO inhibitors and tyramine causes dangerous and fatal hypertensive crisis. MAO inhibitors and SSRIs cause serotonin syndrome and others. Advantages of SSRIs over TCA and others. Selective, well tolerated, currently most commonly prescribed drugs, mainly fluoxetine. Most efficacy, less toxicity, generally free of sedative effects. Less likely to induce mania, less dangerous in overdose. Relatively safe, can be used for psychiatric indication, and less likely to cause anticholinergic effects. Disadvantages of SSRIs. Less high cost, less effective than TCAs in treating severe depression, increased suicidal aggressive ideation, and dangerous serotonin syndrome. End of the topic.